evening, ladies and gentlemen. You are welcome to the Nigerian Society for Colorectal Disorders. First of all, I want to congratulate everybody and wish you also a happy new year. Though this is January ending, but this is our first meeting, so I will still greet everybody a happy new year. This year we are kickstarting our activities earnestly, and today we are having a case report presentation by one of our faculties here. It's my vice president, a person of Dr. Ademola Adeyeye. He is an associate professor of surgery at the Ademola University. I think I'm correct. That is upward. So he'll be taking us through a case presentation this evening, and I want us to be attentive and participate actively because it's quite an interesting one. So the first session of this meeting will take care of this academic presentation, and we intend to finish this first phase over the next 45 to 50 minutes, after which we take on the second session of this meeting. That will be to deliberate on our activities for the year 2023 and also other related matters that we want to talk about. So permit me to welcome on board Associate Professor Dr. Ademola Adeyeye for his case presentation. Dr. Adeyeye, I think the floor is open now for you for your presentation, and I'm going to give you 20 minutes for your presentation. So once it's 15 minutes, you will be allotted. Once that is 15 minutes into the presentation, once it's 5 minutes to the end of your time, you will be allotted. And once it is a minute, you will be allotted. We have to be time conscious this evening. So over to you, Dr. Adeyeye.
Thank you very much, sir. Can you hear me?
Yeah, loud and clear.
Okay, so I'll try to share my screen. Although I wanted to remind you, sir, that we also have a poll to administer.
Yes, we will talk about that during the second phase of the meeting.
Okay, great.
It's okay, thank you. So you have the floor for the case presentation.
All right, just give me a second.
Okay.
So is the PowerPoint presentation feasible?
Yeah.
All right.
It's okay.
Okay.
So this is 8:05 and your time starts now. So you are expected to stop by 8:25.
All right, great. So good evening, everybody. I'll stand on the disease protocol. I would like to make a quick presentation of an interesting case that I encountered towards the end of last year. So it was a 19-year-old female undergraduate student who was seen on the 24th of November 2022 on a self-referral from a government hospital following a local industrial action in that institution. So as at that time, she had complained of recurring abdominal pain of 3 months duration. It had said abdominal distension and constipation of 5 days duration prior to presentation. She had complained that the pain was dull in nature and was worse in the right iliac fossa, but became colicky a few days prior to presentation, and there was a progressive abdominal distension. She also complained of constipation with a preceding history of tenesmus and bloody mucoid stool. She last passed Platosa 2 days before presentation, and so she was obstipated at the time we saw her. She had had a preceding history of weight loss, anorexia, as well as generalized body weakness, but there was no vomiting, fever, and there were no other systemic symptoms. She was nulliparous but had noticed in irregular menses for the last 2 months prior to presentation, and her last period was said to be scanty. She had had an open appendectomy at the onset of the abdominal pain at a private hospital under general anesthesia. They were surprised to know that the specimen was not sent for histology, and she had some delayed healing after the procedure. She didn't come with a referral letter from that area. She had no comorbidities or allergies and had been using herbal remedies and self-prescribed laxatives to open her bowels. And there was no family history of cancer or cancer-related deaths, and there were no family history of comorbidities. She's the first of a set of non-identical twins in a monogamous family setup of 5 children, and she has an elder sister. There was no issue of alcohol intake, smoking, or substance abuse. She is sexually active, and she takes mainly traditional African diet and is university undergraduate. So when we saw
we've lost the sound.
Dr. Adeyeye, we cannot hear you again. Check your microphone, please. Dr. Adeyeye, check your microphone.
Can you hear me?
Okay, go ahead, please.
So she was actually ill and critically ill. She was pale, febrile, anemic, with low pidal edema. Her pulse rate was 128 per minute, and her blood pressure was 128 meters of mercury. Respiratory was normal, and temperature was also febrile. And she had a good saturation in room air. The signal findings were in the abdomen, which was grossly distended with a generous Lanz scar. It was mildly tender with an ill-defined palatable lower abdominal masses. There was a tympanic percussion note centrally, and there was dull percussion note in other regions. Ascites was demonstrable, and the bowel sounds were hyperactive. On the rectal examination, there was a circumferential occlusive rectal mass about 6 centimeters from the inner by 3/4 abdomen. Other regions were grossly normal. In terms of her diagnosis workup, she had come to the hospital with an abdominal and a chest CT scan, and it showed that she had evidence of ascites. This is the liver, and then this is fluid just between the diaphragm and the liver, so gross ascites, but the liver otherwise was grossly normal. And she had a thick rectal wall, not clearly demonstrated on this image, around with narrowing of the rectal lumen. And then she had multiple multiple cystic mass with an enhanced mural wall, possibly ovarian from the radiology report. Uterus was also noted to be bulky with a thickened endometrium and collection. Otherwise, lungs, liver, and other grossly normal. Laboratory parameters were as shown, of note was a potassium 3.1, mildly hypokalemic, and C and C25. Some were taken before surgery.
Please, do you have two devices open because you are having an echo?
Oh, there's an echo.
Yeah, maybe you have two devices open there. So.
Yes, because of the network. Yes, because of the network. Let me try to sort that out.
Maybe if you mute, you can mute one of them and they reduce the volume on the other one. Yeah.
Okay. How's it now, sir?
Yeah, better. Yeah.
Okay, great. So the clinical diagnosis we entertained at our presentation was complete intestinal obstruction in a young patient with rectal tumor. We also noted there are massive ascites with background metastatic, possibly metastatic or primary ovarian tumor. And we also considered that she may have an endometrial tumor because of the CT finding. Based on this combination of multiple tumors, we had to extend diagnosis of Lynch syndrome. So she was stated as per routine protocol, and the parents were counseled on the diagnosis and need for surgery, that she may have possible resections and biopsies as well as a stoma. After consent, she's going to have the midline laparotomy under general anesthesia. So what we found was that she had gross ascites, approximately 4 liters, with dilated bowel and huge bilateral ovarian masses. By the time they were excised and measured, the right was about 1.2 kilograms and the left was about 2.2 kilograms. So in total, she had about 3.4 kilograms of ovarian tissue in her abdomen. And the uterus was noted to be bulky. She had then diffuse peritoneal seedlings and some nodes, but the liver was grossly normal. There were no other evidence of organ metastasis. This picture highlights the ovarian masses being delivered from the wound. This image here shows the bulky uterus. There's some peritoneal seedlings here, and then the dilated bowel loops. So following antibiotic prophylaxis and transdermal prophylaxis, which we're now giving our patients to reduce the incidence of blood transfusion, we drained the acidic fluid, and then we did a bilateral oophorectomy and a loop and sigma colostomy. And she also had a rectal biopsy using a flexible sigmoidoscope to get a tissue diagnosis from down below, and an endometrial biopsy by the gynecologist. And she had routine abdominal wall closure. So she wasn't transfused. The procedure time was approximately 82 minutes, and there was negligible blood loss, and her post-operative status was satisfactory. So this is the picture following the end of surgery with this sigmoid loop colostomy in the left iliac fossa, and this is an image captured from the flexible signals that was done intraoperatively. So her recovery following surgery was satisfactory. The colostomy became functional at the 3rd day post-operatively, and she was discharged on the 4th day for removal of sutures on the 10th day post-operatively. This picture indicates one of our clinic visits before removal of sutures. So, but we had our final histological diagnosis, which confirmed the high-grade infiltrative mucinous rectal adenocarcinoma. She also had bilateral primary serous papillary cyst adenocarcinoma of the ovaries. Sorry for the typography, the endometrial biopsy was not representative, and the pathologist had advised a repeat biopsy. So these were photomicrographs that were sent to us from the pathologist because of the peculiar nature of this case. So the image here shows the serous papillary cyst adenocarcinoma from one of the ovarian tissue that was excised, and this image shows the mucin in the rectal adenocarcinoma that was biopsied. This image here shows the 2 ovarian masses. This is the left mass, the right mass, and it's at surgery. So when we got the comprehensive details from the pathologist, we had to have a counseling session with the relatives and the patient. And we told them about the stage of the disease. It was already metastatic. And she had, based on her age, she was less than 40 years. We labeled this as young onset rectal cancer with bilateral primary ovarian cancer. And we discussed the possibility of Lynch syndrome and the fact that we need to send the rectal tissue and possibly the ovarian tissue for immunohistochemistry. The rectal tissue of note check for microsatellite instability, the KRAS and BRAF status that may determine a choice of adjuvant or palliative therapy. We also discussed the need for genetic counseling and screening. We also talked cancer. There was a need for cancer screening for her second twin, who was a male, and other family members too. And based on the stage of the disease, that she was going to need palliative chemotherapy and possibly biological therapy too. And we discussed the pathologist request for a repeat endometrial biopsy, but based on the finding of the bilateral ovarian malignancies, primary tumors, the gynecologists were more keen to do a completion total hysterectomy for her. Unfortunately, the patient and the parents refused chemotherapy, further evaluation and therapy. And after removal of sutures, we did not see her again. The last encounter we had was in mid-December 2022, or late December 2022, about a month after surgery. And at that time, she was in satisfactory clinical state. The stomach was functioning, abdomen was flat, and she was gaining weight. But she refused clinic follow-up despite multiple phone calls, and we've not seen her since then. So the main talking points concerning this case was the fact that we were seeing a patient with young onset rectal cancer. Again, by definition, patients who present with colorectal tumor less than the age of 40 or 50 years, depending on the guideline that we look at here. And there are peculiarities in managing these patients. And she had bilateral primary ovarian tumors, and we had to consider the possibility of a type 2 Lynch syndrome, hereditary non-polyposis coli syndrome, associated with extracolonic manifestations. And typically, ovarian, breasts, endometrial, and other soft tumors may occur with colonic rectal tumors. And of course, the Amsterdam criteria, which many of us are aware of, needs to be applied in diagnosis here, although we still need to confirm the presentation. And we had to discuss options of therapy depending on the stage. Typically, young patients like this with this kind of tumors do not respond well to conventional chemotherapy. We need to add a backbone of biological agents, usually immunotherapy like nivolumab, which can give us a better response rate. Of course, the family screening and genetics has to come into play, and then also screen the index patient for other tumors like gastric tumors and other soft tissue malignancies comes into play. And the fact that we are seeing such a young individuals, we're getting close to the prime of our life, with our life all ahead of her, interruption education, sexual function, psychological function, and things like this also needed to be discussed. Again, the literature concerning this kind of presentation in our environment is quite rare. I could really lay my hand on one case report of the bilateral ovarian serous and systemic carcinoma from Ibadan that was published in 2017, and then some cases of there are a number of cases, but this was the one that caught my eye from the group in Edo State, in Irua, where they saw a series of patients, adolescents, teenage patients with colonic colorectal cancers. Many of the reviews from many of the people on the call here, the group led by Professor Rabo, the IFE group, and they've all noted the increasing incidence of young onset colorectal cancers in our environment and the high incidence of microsatellite instability. So we definitely need to be aware of it. Unfortunately, these patients had been treated for appendicitis at the onset of the disease when she actually had a more sinister pathology. This is the end of the presentation. I'll be happy to take questions. Thank you.
Yeah, thank you very much, Dr. Adeyeye, for being time conscious and for the elaborate and interesting presentation of that pathology. Really, many things are going through my mind. I'm sure Dr. Iguare, let me just quickly drop the many things are actually going through my mind, starting from the clinical presentation. Because I could imagine the discomfort this young lady has been passing through with that big tummy, laden with giant ovarian pathologies. And from the evaluation and the information given, I think it is a call for all of us as practitioners to stick to the rudiment of medicine that our teachers taught us as medical students. I'm talking about proper patient evaluation, because I think if this lady has been properly evaluated, though I don't know whether the clinical presentation as at that time depicts that of acute appendicitis, but I think if this patient was properly evaluated, somebody should have stuck in his finger into the rectum to discover that there is something sinister there and probably refer to a more qualified person for further evaluation. Probably that rectal tumor would have been discovered much more earlier than that. And if further evaluation is done, then probably the ovarian pathologist too would have even been detected much more earlier than that. So I think that is a lesson that I have learned again from this particular presentation. And for a procedure to be done, and somebody removed a specimen from a human body in this 21st century and not subjected to histopathological analysis, I personally think it is not correct. And as practitioners, we should please correct our younger ones on this practice. No matter where you practice, even if it's a private hospital, whatever specimen you, I think that is the teaching from medical school. Whatever thing that you remove from a human body should be or must be subjected to pathological analysis, because you don't even know what is there. You might think that it is appendix and it might be a carcinoid tumor there. Who knows? But you see, when some of these things are done, we miss a lot of things. And I think we have to be extra careful these days where litigations are coming up here and there. So we need to watch one another's back and at the same time still stick to the rudiments of medicine that we were taught both as medical students and those things that we learned during our residency days. For the tumor markers, really, I'm not too surprised that, especially for CA125, that it got normal value, because I have had one or two patients with ovarian problems like this, and we did CA125, and it came out to be normal. So I actually took up this discussion with the gynecologist, and they were giving me all sorts of reasons why the CA had to be normal. I said, if the CA125 is normal with a histopathological diagnosis of ovarian tumor, then should we be relying on it for diagnosis and all those things? So I think probably that would be another discussion for another day. The peritoneal disease, I don't know whether you thought of a management modality. The bowels are okay, the mesentery are okay, but there's peritoneal spread. I know for now, I don't know whether we have specialized centers that could actually manage that as a locally. Hello, can I go ahead?
Yes, I think go ahead.
Okay, so the management of peritoneal disease is another concern for me. I know it's a limitation in our environment. I think, but we should start thinking about that. So those are just my observations and comments from your presentation. But really, it's quite a challenging one, and I salute your courage and your team members. And one thing is that at this kind of meeting, I am expecting, actually, I expected the radio oncology guys to be in this meeting because I sent a notification of this meeting to them. But again, that is one of the things that I think we have to work on. We have to work on this year to ensure that we have multidisciplinary mode of management for some of these patients. Thank you very much, and let me just leave this seat for other people to make their comments. Thank you, sir. Over to you, Dr. Igwale.
Yeah, thank you so much. This is a very interesting case, and I think it really drives home the reason from what Dr. Adeyeye was saying there, why adequate evaluation needs to be done. And for this patient that is highly suspicious for Lynch syndrome, I wonder if the family history was taken on the mother's side. Has there been any other cases? I know you've highlighted the need for screening, but again, history prior would have been very important. But this is a very rare coincidence to have synchronous lesions going on in the rectum, in the ovary, and possibly in the appendix, which we don't know. And now I will have peritoneal disease. But before I continue, Dr. Segun, you have your hand raised. You're muted.
Can you hear me okay?
Yeah, we can
Can you
hear
hear me
you.
okay?
Yeah.
Yeah, just a really interesting case of a very tragic young lady. I firstly to congratulate the surgical team for palliating this young girl's success.
You're muted. You're muted again. Yeah.
So I was just saying to congratulate the clinical team looking after this lady and for palliating her successfully, because obviously she presented in extremis. And I think that one of the things that's really important in the context of late presentation is palliating patients successfully. And I think it's interesting that the young lady decided to not have any more investigations or treatment for herself, theoretically, or I'm assuming because she wants to have a good quality of life for the life that she has left. So I think congrats to the team for palliating her successfully. I do wonder, I'm not sure this is the right forum for this, but if a young patient has had surgery at a different site and then presented a few months later with clearly advanced pathology, there must be some system for feeding back to that previous surgical department what the findings were, because that clearly has implications for their practice. I find it hard to imagine that this young lady I saw the scar in the picture from the appendicectomy scar. So it's hard to imagine she had surgery with a wound that big and the ovarian masses were not identified. And if you're a surgeon, you're not picking up masses that size, then, I don't want to say you're negligent, but there are serious questions about your practice.
Yeah, thanks very much, Dr. Segun. And I think you've just said what I had in mind, that's one of the quality assurance perspective that we really want to ensure in this forum, like where she had the appendicectomy, that, if we can make contact. I think this is until people learn from their mistakes, then they haven't learned anything. That's the question here. We used to, in medical school, they used to teach us that if you don't put your finger and you put your foot in. And this lady didn't have a digital rectal examination for a 6 centimeter, a tumor in the 6 centimeters from the anal vag. That is just so unfortunate, really unfortunate. And but before I say any other thing, I think I want to welcome comments in terms of how far we've gone in terms of our histology. Particularly, we can see in this case that histology is very key in terms of, again, having a very apt histological diagnosis to be able to go by even molecular analysis to determine what kind of tumor, the biological nature of the tumor, and what needs to be done for this patient. But I want to welcome other comments. And while we are waiting for that, I also want to just seek your view about the need for laparoscopy in some of this, well, not in some of these patients, as a means of diagnosing such patients. Because if this patient had a diagnostic laparoscopy in the course of the appendectomy, that would have obviously been picked up. But I know the resource limitations is an issue, but again, it highlights the need for us to begin to really work towards this area. Like what Dr. Shegun said, that was quite a big extended lens incision that you should have felt the pelvic organs, at least, as part of your checkup and before completing that surgery.
And I think the other thing that's important in a resource-limited environment is that if patients can only typically afford one intervention, then we really owe it to the patients to make sure the first operation they have is the correct operation. It's, if you're having to pay for multiple operations, multiple investigations, then in terms of just pure human compassion, it's crucial that people are getting the best care they can the first time they encounter medical practitioners.
Yeah.
I think the challenge, sir, really is multifactorial, especially in a country like Nigeria, where people do things because of monetary benefits. In fact, this lady might not even be having features of acute appendicitis, but just for the practitioner to be able to benefit something from the patient, so they will just cook up the thing. And you see, the funny thing is that people that do this kind of thing are people that are not even qualified to even take on extensive surgery, assuming that he met probably a ciccal tumor at that appendectomy. What was he going to do? So these are the kind of things that, unfortunately, there are no strict job descriptions for different cadres of practitioners in our country. And I think that is what is even confounding some of these things. So it's quite a big problem in our hands, and we hope that probably in the future, maybe there will be some review of our job description according to your how will I put it now? To your certification. Let me put it that way.
So the question then is, how do we advance this? Because we can't keep having this and we haven't made any progress. This is a powerful association now, which I think can be, a driving force to kind of begin to create this awareness that, people just can't be doing everything.
So, well, I have suggested it before some years ago, but I think we still need to be talking about it. I think one of the easiest ways to get some of these messages back to the first person who manage is during our NMA meetings. During probably our scientific meetings at NMA, we should not be discussing everything about money, association deal, who is contesting for president or not. We should be discussing some professional things too. Like this case now, wherever Dr. Adeyeye is practicing, maybe if he can just discuss with the NMA schools during their next probably quarterly meeting to bring up a discussion around this case. And at the end of the day, the lessons learned from that discussion will be that know your limitation. Okay, if you are practicing where you have access to specialists within a radius of about 10 kilometers, you don't need to experiment with a human being because that person is an integral part of his own nuclear family. So when you are not sure, forget about the monetary benefits. You can always refer to somebody. If you want to join them for the surgery, why not? You are free to join them. You are a medical doctor. But again, I think NME still has a big role in sorting out some of these things, so that it will be like a two-way feedback system.
Yeah. Dr. Rabo?
Thank you very much. Quite an interesting case. My first impression when I saw the girl's tummy was that could it have been a pseudomyxoma peritoniana?
Exactly.
Ruptured mucocele of the appendix or something. And of course, the size of that scar, the length, meant it must have been quite a tough operation for whoever did it. So having not sent whatever I took out for histopathology was criminal, in my opinion. But having said that, this question is to Dr. Adeyeye. At the exploratory laparotomy, was the pelvis frozen in the sense that could you jiggle around the rectum while you were inside the abdomen? Because I'd really love to know, is this like a transperitoneal spread to both ovaries? Now, the fact that we have different histopathological reports, sometimes it doesn't mean that it's not from the same tissue. So I'd like to know whether some of these peritoneal seedlings were a lot more prominent in the pouch of Douglas, you know, and maybe it could have been a transcoelomic spread. Those are my questions. Thank you.
Yeah, thanks, Dr. Rabo. I think your comments are very valid. Like I actually wrote it down when he was talking, pseudomyxoma, but that was what came to my mind at the beginning when that appendix was not sent for histology. But however, the ascites wasn't mucinous. So if it was pseudomyxoma, then you actually expect mucinous the exudate from the peritoneum, and then the CT scan would have shown all those other pathognomonic features like scalloping around the area. So again, and then the liver, that there would have been those scalloping that would tell you that it's pseudomyxoma. So that kind of ruled it out for me.
I mean, that was just my thought initially. Right?
Yeah, that was my exactly. I actually wrote it. I wrote it on a piece of paper. But the other thing was even the tumor markers. I don't know why they elected for CA and CA125 and left out CA 19.9, which would have been a marker for the colorectal cancer. But I think, again, the learning points here for us is to actually inform ourselves so that in further management of these patients, we can actually, because if this was a colonic disease spreading into the ovary, which is unlikely bilaterally, and the ovaries obviously they looked like they were freely mobile, so they were not attached to the contiguous organs. So again, you could still have transcoelomic spread. It's not unlikely, but it's just a conundrum, and it's very unfortunate case. Dr. Shegun, you wanted to say something. Please, if you want to make comments, can you just indicate by, showing the raised hand, and we can call on you.
So the comment I was going to make when I think Dr. Reginald was talking about, or yourself was talking about feeding back and what's the best way to feedback. And I don't know if there is any kind of practice of morbidity and mortality. So many units around the world would typically have a monthly or 6-weekly or 2-monthly M&Ms meeting where patients are reviewed who've had complications, and not so much to find blame, it's not a blame culture, but it's more around what things do we need to learn from our complications, because all of us who are surgeons know that you only get better when you learn from your complications. If you don't think you have complications, you're in denial or you're delusional. if you're learning from your complications, then you will get better as a surgeon. So I think whatever we do as part of this society, a really good thing to think about is the mindset that says, how do we have more of an M&M's culture as part of our unit educational activities, and also as part of as a society together, because that's how you learn.
Yeah, my other thing I want to just add to that is we have to then start looking at a type of enforceability, you know, a body that can really, you know, enforce some regulations. Maybe it's the NMA regional meetings, for example, in Ilorin, where this case may have been done. There should be a regional association there that can actually, if we want to improve the outcome of our patients, if we want to make our practice patient-centric, then these are some of the things we can begin to think about. I know even the M&M in various hospitals may not be enforceable outside, like the guy that did this appendix. Only God knows where he is, and if we ever know the repercussions or the and the outcome of this patient. So that if there's this network, then people will become conscious of the fact that my work can be checked out, because everything we take out goes to the lab. And if you do your colorectal surgery, there are quality indices that has to be looked at. And you go for an M&M and your colleagues, your peers review it. So when you have all these things in mind, it drives you to improve your quality. And until such a thing becomes available, I think I saw Professor Ugu as a professor there. I was just wondering, are there things we can do to begin to set up enforcement, systems to make people, at least people, accountable to the organization for what they do?
Thank you, sir. And Happy New Year to all of us. Thank you. I think this is quite an interesting presentation, and you can see that it has brought up a number of issues. There are quite a number of things I can see here. The fellow who did the surgery, this is a common story in Nigeria. It's not new. And we do not seem to pay attention to these problems. Oftentimes, issues like this happen to the very poor, the underserved in our society. They don't have anybody to speak for them. And the doctor has collected the money and he's gone. At the moment, I have a similar case like that. And after doing the surgery, I had to trace the fellow. Luckily, we were able to get his number, and it turned out that actually he's working in a general hospital, and I did not think that he was qualified to do the surgery that he did. I suspect that this may be the same situation going on. There are things that we can do for ourselves, like somebody has suggested. NMA, MD-CAN, resident doctors meeting. Why is it that they have no forum for medical education? There is none of them discusses anything about residency training. None. There should be a forum where there should be a meeting where issues like this could be discussed. Nobody talks about residency training, so we do not know if the quality we have today is going to be sustained. And sometimes this type of surgery, from my own little experience, they come from residents. Sometimes not surgical residents. So there has to be, I don't think we are looking at the future. If we have to look at the future, we'll start now. There has to be checks and balancing. Yeah. Our meetings should not be like Adejumo said, and these meetings should not be only how we get more money. What is the quality of the training we are giving to our residents. Do I allow these our residents to say their mind? Why is it that MDCAN is not discussing this? NMA is not discussing it. ARD not discussing this. So my answer to this is that there are things that we can do, but it's only when we meet and start discussing this. Then somebody will now know that there could be repercussions. And the culture of collecting money and kicking out your patient when it's not convenient will stop. Perhaps I should make a comment about management of this case. I want to really applaud those who cared for this patient. But I was just wondering, doing an intraoperative proctosigmoidoscopy, fantastic. Couldn't that have been done earlier? That's my question. And if the tumor is so low, couldn't that have been identified much earlier? Then I think also that collaborative management with O&G, with gynecologists, should be recommended. I think this is where I intend to stop. Thank you very much.
Thank you, Professor.
Thank you, sir. I could see Professor Osime and Professor Bakari too. I think they are in the house.
Okay.
Professor Osime, sir. Professor Osime.
Yeah, thank you. Thank you very much for recognizing me.
Okay, Prof.
I think
yeah.
Professor Gu has mentioned some of the things, but I think that the way I will look at it as a lawyer is that we need to give more lectures during such meetings on issue of what comprises medical negligence. This borders on negligence. And because our people are largely uneducated, but that will soon stop. I can tell you that will soon stop. I mean, you have many cases already going on. I can tell you several. Those days, when things like this happen, you think nothing will happen. But right now, people are beginning to know their rights, and they are pushing it. And we should let our colleagues know that it's not going to be business as usual. The only issue there is that because of the clause, you are not supposed to instigate litigations against your colleagues. That's also a problem. If you look at the MDC and the handbook, you'll be your brother's keeper. But when that our brother become reckless, what do you do in order to protect the vulnerable patient? So that's the aspect we need to look at. I think that I will be willing one of these days to give a talk here on what the common things that constitute medical negligence that we just overlook, and the patients are mismanaged and nothing happens. If we have that, I let them know the possible implications of this, I can tell you. And we also have cases that have been decided, maybe in other climes, bordering on similar things. It can be brought up for discussion so that people will know that what they did, that they went free in quote, can actually lead them into some problems. If we have that kind of forum to sensitize people on the need to have good practice with minimal issues or with malpractice or negligence, I think that forum is more desirable. Thank you very much.
Yeah, thank you, Professor.
Thank you, Professor Sime. Professor Bakari.
Yes, good evening. Sorry, I joined the forum lately. All I want to say is this common mishap, we also used to have it in our environment. The one I saw recently is somebody is a resident who is not conversant with transvaginal hysterectomy. He went and harvested the woman's bladder. So it took us time to bring back that woman to normal. I think NMA, MDCN should come to the fore to see that those people. What I did is I had to trace the resident who did this thing and made him to pay the subsequent cost of the surgery. So I think if we continue to trace them and talk to them, I think it will, in a long way, make some difference. And then we have to talk to NMA also to bring this into the forum. Instead of using their platform for political things, they should be talking about this thing there. Thank you very much.
Thank you, sir.
Thank you so much.
But just like what the two or the three professors have said earlier, most of these things happen with people that are not even qualified, and they get away with it. My problem is that when a qualified personnel does a surgery and probably has a complication, that is when people will be suing the consultant or the specialist all over the town. Some of these things that probably medical officers do, they get away with it. In fact, that is the irony of things on ground. So I still believe NMA has a lot of role to play. Working hand in hand with MDCAN and probably the Medical and Dental Council, they have a lot of role to play in describing, in giving job description according to your level of certification. But just like Professor Ugu said, we need to start now. We need to start now. Thank you very much, sir.
Okay, I don't know how much more time we have on this segment, but I can see Dr. Shegun's hand is up there. Maybe we'll take that as a last comment before we,
Yeah, sorry for over speaking. It's just a thought that if you want to resolve a problem, one of the things you have to do is quantify the problem. And so in the UK, certainly there are different scales of surgical mishap or misadventure, if you like. So there is just regular mortality and morbidity. Then there is also significant adverse events. Then there are also what we call never events. So these are things that should really never happen, like removing the wrong kidney, like leaving swabs in the, like removing a bladder rather than a vagina, than a uterus, for example. So I wonder if one of the things this body can start to do, if you like, is start to gather, audit some of these events as they're escalated, so that you start to get an idea or a map of where some of these, just to get an idea of the scale of never events and adverse events, because that will start to give you a body of evidence you can start to work from, just in terms of improving the general practice culturally.
Yeah, thank you so much. I just agree with you, just in closing, just to say that we have to start from somewhere, and it really calls for accountability. And your view or your stand may not be popular. There has to be a way. Where I practice, nobody does cases outside if they are not certified to do it. Not even the private hospitals will be allowed to do it. They will not allow somebody to come to their center to do cases that they are not accredited for. And that system of accreditation has to start from somewhere in Nigeria. It's not every backyard clinic that can do appendicectomy or prostatectomy or whatever. So that people should begin to know their limits. If you want to treat malaria and treat typhoid, that's okay. But when it comes to a point where you are doing hysterectomy in the back garden, or you are doing this kind of, these issues when you are not certified to do it, I think the Medical Council has a role to play. The Medical Association has a role to play. And I think it can be escalated from there, and let there be consultation in terms of, people knowing what their limitations are and what they are allowed to do. They can make money, but not at the expense of people's lives,
Thank you very much, sir. Dr. Adeyeye and the team that presented, we appreciate you for opening the year with that wonderful presentation. That brings us to the end of the academic session.